which brings us on very nicely to this whole topic around sort of conversations, what happens in conversations or what we perceive happens. I'm delighted to be joined by Nicolaj. Nicolaj is Chief Advisor for the Danish Committee for Health Education and has really led the whole implementation of empowerment approaches, self-management, everything we've been talking about today. Pretty much, so anything which has happened in Denmark around this, he has had his finger in the pie somewhere or another. And not only that, he's spread his fingers to Moldova and Switzerland and lent his support all across. And so, Nicolaj, I'm delighted to welcome you and your experience, and I shall hand over to you.
Thank you, and thank you for inviting me. David, you said something just before, an advice is not a word of God, and that got me to think about an old joke my CEO always tried to build in conversations about empowerment and conversations between healthcare professionals and patients. And this joke is that, do you know what the difference is between God and a doctor? Well, God knows he's not a doctor. I hope there's a lot of doctors out there sitting bitching of me now, because it's a good joke with a lot of truth in. Just a very short introduction about the committee. Below the line, you have the members of the Danish Committee for Health Education, and above the line, you have all the organizations that we're working with in Denmark and abroad. Just to show that we're sort of a non-governmental organization, but with close links into the public healthcare system in Denmark. As well, we are still a small country, and the Copenhagen metro is only 4 lines, and we a few years back wanted to try to make a visual board of what we've been doing around self-management support, and try to get inspired by the London Underground map. And one of the lines, line 5, the green line, we have these 2 innovative projects that we've been participating in, mentoring and audio recording. These are the 2 insights I'll give you today, and both of these insights, the first one, guided self-determination, and the next one, audio recordings, are actually sort of reactions to experiences learned with using shared decision making. Because shared decision making is something that no one can sort of be against, but making it happen, we just saw Jonathan describe the framework, and we saw especially Kat, but also David emphasizing the challenges of shared decision making. And at least in a period in Denmark, shared decision making, when it came to the point, was that the doctor gave you 2 solutions and then you could decide. And so what we've learned in Denmark over the years, because I agree that shared decision making, Jonathan mentioned the 60s and 70s, I would agree that it's been a long journey towards this, but it all, even whatever we build up of systems, whether we call it shared decision making, guided self-determination, and so on, it all steams down to who has the power in the communication relation. And the problem is that even if you are trained and if you are a very good healthcare professional, there's also some structural biases that sort of give you the platform for communicating with your patients. And I see in the title guided self-determination sort of a step further than shared decision making, where shared decision making emphasizes that this should be a shared decision. This moves up a little step, that what the goal is actually that the patient do the determination, because the patient is the one who has to live with the consequences for the rest of their life. And I think Kat has some great ways of emphasizing this dilemma that well, even if we have a shared decision, I'm the one who has to live with it. So and now the guided self-determination, and you can see a publication, and you can look up that it's Vibeke Softman who is the main character behind developing this tool, you could say. It started off as a physical tool in the clinic at the hospitals around diabetes care, especially around diabetes care for pregnant women, where you needed to have some quick lifestyle changes in order to avoid some of the problems by being diabetic and pregnant at the same time. So they developed these materials, papers, where that sort of forced the healthcare professional to ask the right questions. So it started off, and I will not be presenting the material here, we don't have the time, but just to say that it started off actually as a piece of paper that actually was meant to swift the power in the conversation. So instead of and just a quick callback to what David said, that he don't think that his personal GP was doing something special for him being a doctor. Well, I would never disagree with you, David, but I would say that interesting dilemma in some way. I mean, once there was someone who said to me, bring together an engineer and a psychologist, and they will not be able to talk at all about the profession. And I think that there's actually something when doctors talk to doctors. There's a certain understanding that sort of creates a different arena for communicating, but just, yeah. Because it goes down to the power, who has the power, who has the upper hand in the conversation. And these products they sort of made in a physical way in this guided self-determination actually forced the healthcare professional to give the power to the patient. In a cool, non-provocative way. And then this doesn't mean that suddenly it's the patient who has the responsibility for disseminating the right knowledge and all this kind of stuff, but it's the patient that in the end has the responsibility of the situation and the life to live afterwards. So we need to make sure that the power is in the right place. Now the guided self-determination system is online, and in Denmark we have a website called, well, translated health.dk, where you as a citizen and a patient can log on to your own medical record, and the healthcare professional that you invite to look at your record can look at your record as well. And in this system you have the guided self-determination product as well, so you can use them for the conversation and for the ongoing conversation in determining what's really important for you. And so it creates a common structure for communication to the patients, where you leave the last piece of power in the hand of the patient, and this can always be sort of you could call it a trade-off, because for some patients, Jonathan mentioned that when he's lying unconscious after a traffic accident, he would not be involved in the determination, he would just be treated. And of course, there's a lot of situations where you need to give the power to the healthcare professional, but it's just another road to giving the power. Instead of the power being at the hand of the healthcare professional from the start, now it's actually in a common process that the patient give the power to perform. And what they've shown in numerous research, especially with the physical, not yet on the online setting, is that it increases the level of self-efficacy in patient, and that leads to more control of your own life and a better everyday living, and sort of makes the job done. So this was the one example of showing how you will simple tools actually can change the power of conversations. And just to give you a small insight, one of the tools is, as you know, probably know that you can have this regarding pain. You could have the VAS scala from 0 to 10, but in the guided self-determination system, we actually use that scale to frame the conversation. So now the patient can say what level of pain are we talking about, and then that's the start off for the conversation into whatever. So we're just using common and new developed tools in this system to sort of frame the communication setting. Another interesting and quite provocative action done in the Danish healthcare system is that we actually now have a hospital in the center of Denmark that have structured audio recordings as a very natural part of the patient-doctor conversation. And this, I've been talking to colleagues in the UK before, and we've been discussing the provocative part of this, because audio recordings, how will the patients not use that for complaining and for being difficult patients and stuff like that. But let's face it, all people, including patients, already have an audio recorder in their pockets, the mobile phone. And I'm pretty sure, and we have research in Denmark too, that shows that if you're uncertain whether you'll get a good treatment and service in the system, you tend to record the conversation. So why not instead use the conversations as a structural setting for swifting the power of the communication? Because if you suddenly have a patient who can re-listen to everything said, who can share it with their significant other, maybe with another doctor as well, then you actually sort of level out the power in the relation, in communication relation. Because as a patient, if you're sick, when you're meeting with the doctors, usually you don't have that much time. Usually you have a lot of things to cover. It's so cool that you're able to actually go back, re-listen to what's said, re-listen to the decisions made, and so forth. And in this way, we see in Denmark a dramatical shift in who's in power and what happens afterwards. And as you can see, I've listed a quotation for a study as well, showing that this is true. And actually, it's so cool now that in this hospital, again, Health DK, where you have your electronic patient file in Denmark, now they can actually embed the audio recordings as MP3 files in the patient journal, so the other doctors and healthcare professionals can listen to them as well. But what happens in practical is actually that the healthcare professional or the patient can open up the phone or an iPad and start recording the conversation, and it'll go directly into a secure system where nobody else can listen to it and stuff like that, and in the end it becomes part of your journal. What we've learned in this process was that if we just did the audio recording, we got, well, two-thirds of the way to the goal of better communication. But actually we needed to train the healthcare professionals as well in existing in this new arena where you're actually recorded. It created some kind of anxiety at what they did was they tested it first at one part of the hospital, and then they implemented it in the whole hospital. So the training of healthcare professionals to use the recordings to actually emphasize the importance of using the recordings of the patient was part of it. So now we have they have structural training of healthcare professionals, and in this COVID-19 period where everything have gone online, now it became e-learning on demand. So all new employed healthcare professionals at this hospital will get introduced to this from day one. This is also another problem with shared decision making and guided self-determination and all these kind of systems or tools to improve conversation that we need to make sure that all the new employees know the systems as well, and this has done quite nicely at Sygehus Lillebælt in Denmark. And in the end, now everybody is happy for these audio recordings, because it's become a tool for the progression of the conversation with different healthcare professionals. Kath mentioned the problem of seeing a new physician every time. What they see of this hospital is that It's still a wish from the patients that if it's possible, they would like to see the same, but the number of complaints about the change in healthcare professionals has been dramatically reduced after using audio recordings, because it sort of disseminate the knowledge from the conversations in a much nicer way than in doctor's language in a journal. So it supports patient empowerment in a very direct way. If you are interested in more, please write me or check out the references in my slideshow. Then you can look up the people working directly with it now. I've been part of developing the training for healthcare professionals in these two projects and not directly in the conversation with patients. Thank you very much.
Thank you, Nicolaj. That was fascinating. The idea of us all being able to record all of our consultations and be able to take it home and play it to our family or what have you, I think would absolutely scare a lot of clinicians completely to death in the UK. I have a thought of their words being sort of replayed, as it were. So I'd be really interested at some point to hear more about that and some of the barriers to implementation.